Καλησπέρα σας.
Όχι ακόμη. Σε 2 λεπτά. 3 και 2 να ξεκινήσουμε.
Okay, 2 minutes. Καλησπέρα σε όλους που μας κάνουν την τιμή και σήμερα να παρακολουθούν τη σειρά των μαθημάτων Υγεία και Θρησκεία. Σήμερα έχουμε την εξαιρετική τιμή και ευκαιρία να έχουμε μαζί μας έναν από τους κορυφαίους Αμερικανούς καθηγητές από το Πανεπιστήμιο του Harvard, τον Professor John Peteet. It's a great honor, Dr. Peteet, and privilege to have you with us today. And allow me to introduce to our listeners in Greek, so I apologize for that. But we feel very, very, very excited having you today because you essentially introduced the idea of these lessons to our Greek culture, sort of. Ο καθηγητής John Peteet τελείωσε την Ιατρική Σχολή από το Πανεπιστήμιο Κολούμπια και μετά έκανε την εκπαίδευσή του στα πανεπιστήμια του North Carolina Chapel Hill και κυρίως εκπαιδεύτηκε στην ψυχιατρική στο Massachusetts General Hospital and Massachusetts Mental Health Center. Ο καθηγητής Peteet είναι σήμερα ψυχίατρος στα 2 μεγάλα νοσοκομεία του Πανεπιστημίου του Harvard, το Brigham and Women's Hospital και το Dana-Farber Cancer Institute. Το έργο του είναι πολύ σημαντικό, όχι μόνο στην ψυχιατρική, αλλά ακριβώς αυτό που συζητάμε και θα συζητάμε στα επόμενα μαθήματα, στη σχέση μεταξύ υγείας και θρησκείας. Θα μου επιτρέψετε να διαβάσω από το δικό του κείμενο στα αγγλικά λίγα πράγματα, για να σας πω ότι από το 1978 ξεκίνησε στα πανεπιστημιακά νοσοκομεία του Harvard να κάνει την κλινική του άσκηση σαν διευθυντής της ψυχοσωματικής ογκολογίας και αργότερα σαν διευθυντής του προγράμματος για την ψυχοσωματική ιατρική. Εκεί βλέπει καταρχήν ασθενείς και τις οικογένειές τους και εκπαιδεύει γιατρούς, ψυχιάτρους και ογκολόγους, ώστε να μπορούν να αντιμετωπίσουν με διαφορετική προτεραιότητα τις διάφορες ανάγκες των ασθενών. Ιδιαίτερα εκπαιδεύει τους εκπαιδευόμενους γιατρούς όταν περνάνε από την ψυχοκοινωνική ογκολογία και βλέπουν τους ασθενείς που βρίσκονται σε ένα τελικό στάδιο της νόσους του, και συγχρόνως εκπαιδεύει φοιτητές της Ιατρικής του Πανεπιστημίου του Harvard. Μάλιστα, το πρόγραμμά του στο Psychosocial Oncology και Palliative Medicine είναι από τα πιο περιζήτητα προγράμματα μεταξύ των φοιτητών. Εκπαιδεύει πολλούς κλινικούς γιατρούς στα θέματα της πνευματικότητας και τις θρησκευτικές διαστάσεις των ασθενών, και μαζί με την Dr. Mary McCarthy έκανε ένα πρόγραμμα, ολόκληρο εξάμηνο για τους ειδικευόμενους στην ψυχιατρική, το οποίο βραβεύτηκε το 1998 από το γνωστό Ίδρυμα John Templeton. Από το 2006, μαζί με άλλους καθηγητές από την Ιατρική Σχολή του Πανεπιστημίου του Harvard, έχουν οργανώσει το κέντρο για την πνευματικότητα και προσφέρουν μαθήματα πνευματικότητας, healing και ιατρικής, και είναι και εκδότης ενός σχετικού βιβλίου. Σε αυτές τις επαφές του με ειδικευομένους και φοιτητές ιατρικής προσπαθεί να τους δείξει τα βασικά και την σχετική πρόσφατη βιβλιογραφία, πώς να παρουσιάζουν, πώς θα έρχονται σε επαφή με τους ασθενείς τους και πώς θα τους βοηθούν. Βλέπουν τον ασθενή σαν μια συνολική προσωπικότητα, χρησιμοποιώντας ψυχοδυναμικές πληροφορίες και προσπάθειες προσέγγισης. Έχει εκπαιδεύσει και εκπαιδεύει, όπως είπαμε, και εκπαιδευόμενους στην ψυχιατρική, πηγαίνοντας μαζί τους σε επισκέψεις κλινικές ή βλέποντας στα εξωτερικά ιατρεία. Το ενδιαφέρον του το ακαδημαϊκό είναι οι ψυχολογικές μορφές της ογκολογίας, η αντιμετώπιση των εξαρτήσεων και ακριβώς πού είναι το όριο μεταξύ ψυχιατρικής και πνευματικότητας θρησκείας και ποια είναι τα ηθικά διλήμματα και οι μορφές της κλινικής ιατρικής. Έχει επενδύσει και κάνει focus στον ρόλο των κλινικών γιατρών με τις ανάγκες τις πνευματικές των ασθενών και ιδιαίτερα των ασθενών με καρκίνο που ζητούν κάποια βοήθεια από τους γιατρούς τους. Έχει συμβάλει σημαντικά στην όλη ψυχιατρική οικογένεια, τόσο με ένα βιβλίο που εκδόθηκε από την Αμερικανική Ψυχιατρική Εταιρεία, αλλά και τις ομιλίες του στα ετήσια συνέδρια, όσο και ηγούμενος ειδικών επιτροπών της ακριβώς αυτής της μεγάλης εταιρείας της American Psychiatric Association. Επειδή οι κληρικοί είναι αυτοί που πρώτοι βοηθάνε τους ασθενείς ή πολλούς ασθενείς και ότι η προσπάθεια αυτή μάλιστα στους ψυχιατρικούς ασθενείς να ξεπεράσουν το στίγμα της ψυχιατρικής θεραπείας. Έχει ειδικά συνεργαστεί και εργάζεται με τους ιερείς και τους άλλους ηγέτες των διαφόρων δογμάτων και μάλιστα πρόσφατα στο Mental Health και Faith Community Partnership στο τμήμα Religion, Spirituality and Psychiatry του World Psychiatric Association. Έχει δεχθεί το μεγαλύτερο βραβείο που δίνεται σε ψυχιάτρους, το Oscar Pfister Award, και συνεχίζει να είναι και ακαδημαϊκός, εκδίδοντας διάφορα βιβλία ή παρουσιάζοντας διάφορες έρευνες και συνεργαζόμενος με άλλους ακαδημαϊκούς πάντοτε στα θέματα αυτό, όπως παραδείγματος χάρη πρόσφατα ασχολήθηκε ιδιαίτερα και δημοσίευτη σε ένα θέμα λεπτό που είναι το Physician Assisted Dying, το οποίο απασχολεί όλο και περισσότερο την παγκόσμια κοινότητα. Είναι πραγματικά πολύ σημαντική η προσφορά του μέσω του προγράμματος του Harvard Initiative on Health, Religion and Spirituality, με πολλές κλινικές μελέτες και βεβαίως εκδόσεις, σεμινάρια, διαλέξεις. Θα τελειώσω την εισαγωγή επικεντρώνοντας ποιος είναι ο σκοπός του έργου σύμφωνα με τον ίδιο και θα σας το πω στα αγγλικά. My aim has been to bring conceptual clarity, scholarly rigor, collaborative leadership, and innovative teaching to the treatment of the whole patient. It's a great honor to have you, Professor Peteet, with us. Please share your thoughts with our audience. Thank you.
Thank you very much for that kind introduction. I don't think I've had one so long in my life, and I hope it's all true. I do appreciate this invitation and admire what you're doing and wish I could be there in person. Let me see if I can share my screen. So what I would like to do is follow this outline with a little bit of history at the beginning, talk a bit about the spirituality-medicine interface now, some working definitions, a little bit about relevant research, and then spend more time on the potential roles for a physician in the patient's spiritual life, concluding with some clinical and ethical challenges for addressing spirituality and treatment. I have to qualify what I'm saying by noting that I'm coming from a psychiatric and an American perspective, even though I do work in a general hospital. And so I hope that we can make some of those translations where they're relevant. For a good bit of history, the role of priest and healer was intertwined, as you can see in this depiction of the Temple of Asclepius. But with the Enlightenment and Post-Enlightenment developments, there were changes in the way Western culture thought about the relationship between medicine and faith. Some of the key figures were John Locke and Isaac Newton, who advocated the analysis of complex phenomena in terms of their summative parts. And so for quite a while, there was a split between medicine and spirituality. There was a time earlier in this century, in the last century, when it was very unpopular to talk about the relationship between spirituality and medicine. Freud had something to do with that as a devout atheist who was trying to make psychiatry scientific. But in the last decade or so, couple of decades now, we've seen a lot of developments at the medicine spirituality interface. 12-step spirituality is widely valued in the US. Palliative medicine includes spiritual care among its goals. Psychoanalysts such as Anna Maria Rizzuto have understood faith better than Freud did. Mindfulness has become mainstream within psychiatry. There are many courses, papers, books in this area. This book here is the text that we use in our medical school course. Spirituality is now seen as a risk or protective factor within psychiatry. Most patients who are surveyed want their religion or spirituality included in their therapy. Dr. Lynus mentioned the Mental Health and Faith Community Partnership. The World Psychiatric Association and the UK's Royal College have statements on religion and spirituality in psychiatry. And as I mentioned, research is burgeoning in this area. Here's a sample paper from Harvard, the School of Public Health, analyzing the nurses' longitudinal study in which data from almost 90,000 women was analyzed and showed a 5-fold reduction in suicide rates with self-reported attendance at religious services. But there are still a number of reasons that clinicians may neglect spirituality. There's a lack of consensus about definitions. Clinicians often feel inexperienced. This term countertransference that we use in psychiatry refers to our own emotional reactions that are not always conscious to this area. We have unresolved spiritual concerns of our own that we don't necessarily want to be asked about. There's a lack of time, certainly, to do this area justice. There's sometimes concerns about boundaries, what's appropriate, and role confusion. What is our role really as physicians in a patient's spiritual life? I'll start with talking a little about working definitions. Spirituality is generally thought of, even though there's no one accepted definition, as having to do with one's relationship to the transcendent, to God, beauty, ultimate values that gives one's life meaning. This ambiguous definition makes research difficult. And so religion or religiosity is often used more in the research literature, referring to a tradition of spiritual beliefs and practices that are shared by a community, generally more organized, with more accountability and reference to authority, and generally correlated with better health outcomes, as Harold Koenig at Duke has shown with his summary of the research. But it can involve struggle and distress. Freud called the term Weltanschauung or worldview a person's overall philosophy of life or operating system. And he defined it as an intellectual construction which solves all the problems of existence uniformly on the basis of one overriding hypothesis. And some have identified 4 major worldviews: radical materialism, secular humanism, pantheism, and monotheism. But there are also people who have talked about secular analogs to religion in terms of the kind of story that people use to justify their lives, whether it's family, sports, politics, the things that are most important to them in a practical way. Just to say a bit about the summary of serious illness literature, Dr. Balboni, I think, will be talking more with you about this later in the course. But the data suggests that religion and spirituality are important to patients and are associated with improved coping with illness and quality of life. Many patients, again, though not all, want religion and spirituality to be acknowledged in their care. And practitioners don't appear to be performing spiritual care. There is, though, growing support for incorporating religion or spirituality into patient care. In the US, the Joint Commission, which regulates healthcare organizations, mandates a routine spiritual assessment. The American Academy of Medical Colleges includes some kind of attention to spirituality in medical education, and medical associations such as the National Cancer Institute, the National Consensus Project for Quality Palliative Care, also make similar recommendations. Specifically, the National Consensus Guidelines for Quality Palliative Care mandate assessing and addressing spiritual concerns, recognizing and respecting spiritual beliefs, providing spiritual support, and allowing the participation of spiritual communities in patient care where it's desired by the patient or family. So I'm going to suggest that there are three potential roles for a clinician in a patient's spiritual life. One is understanding the patient more deeply. Two is responding to distressing spiritual problems. And three is helping patients become more integrated and whole. So start with a spiritual assessment. Spiritual assessment provides a window into patients' core values, their culture, their important relationships, trauma history often, some of the resources and practices that may be helpful to them in the course of illness, and supports. And as I think about the elements of a spiritual history, even though there are a number of mnemonics and brief sets of questions that are now out there for screening, I think in terms of these three main categories. First is listening for what's valued, sacred, or deeply troubling in the patient's use of words like courage, despair, suffering, and peace. And then following up by asking, what's the most important aspect of one's background or identity? And have they been a spiritual or religious person? We routinely ask that at the Cancer Center when we see new patients. And if so, in what way? And then actively exploring by following up on practices, relationships to God, if they mention God, and struggles with guilt, disappointment, or doubt. There are, as I mentioned, a number of spiritual problems associated with physical or mental health. Jehovah's Witnesses refuse blood products. Christian Scientists refuse the medical. We're now familiar with a number of anti-vaxxers who ground their refusal in religious beliefs. There are religious cults. Religious patients and families sometimes pursue miraculous healing at the expense of scientific medicine. We see sometimes unhealthy guilt or passivity reinforced. And conditions such as depression are regarded as spiritual. Some patients may be struggling with whether they can still believe after a serious illness is diagnosed. The discipline of palliative care has done the most to identify spiritual struggles as part of their mandate to treat the whole person, as you can see in this quote. And an example of this might be a time when the team requests an urgent evaluation of the mother of a 5-year-old girl with leukemia. On learning that her daughter has relapsed, she becomes distraught and asks, "Why did God do this to me?" So usually when I present this, I ask for some input from the audience about how they would think about a situation like this if they were in it. And usually the first answer is to understand a little better what she means, to listen, which I think is a great answer, because it's not clear here if this is her idiom of distress, if she's been traumatized before in some way, if she has a relationship with God that has disappointed her in the past. So it's not clear yet whether she would benefit from a referral to a chaplain for more explicit spiritual support, or from more exploration of her trauma history or support in just dealing with this intense loss. I don't know how much you have hospital chaplains available to you there, but they're of a great help to us here in the medical setting when patients do have spiritual concerns. Here's another example. Surgeons requested help approaching a single woman in her 50s who was reluctant to consider potentially curative surgery for newly diagnosed breast cancer. She appeared anxious, but she said she was putting her faith in God to heal her. So the question was how we could help the surgical team approach her. And some of the suggestions that came from one of my fellows are as follows: to acknowledge the importance of her faith, to agree with her that physicians treat while God heals, to indicate that many members of the hospital team are people of faith, and to offer to include her spiritual supports. There's some nice discussion of these issues in a paper by Dan Somasi and JAMA in 2006. And then the third role that clinicians can have, helping patients become more integrated and whole. When I think about this, I usually think in terms of fostering a helpful spirituality as a response to patients' existential concerns. And these might be concerns in the areas of identity, hope, meaning and purpose, morality, or autonomy in relationship to an ultimate authority. Starting with identity, core beliefs about who one is in the world are important at points of change. For example, a previously healthy businessman who has an MI, a heart attack, they have to rethink what's really important to him, who he is at his core. Patients may or may not trust clinicians based on who they perceive them to be. But a spirituality can ground someone's identity when it's engaged and transformative rather than static and somewhere on the shelf. What I'd like to do is try to switch to show you a brief video to illustrate the transformative role of spirituality. Let me see if I can stop share and go into the video. Marsha Linehan is a psychologist who's well known in the States for developing DBT, dialectical behavior therapy, which is the first evidence-based treatment for borderline personality disorder. And a few years ago, she gave a brief talk to the New York Times about her own experience coming out of a period when she was frequently hospitalized for injuring herself younger in her life.
I was sitting in the sitting room right outside the chapel, which I will never forget because I was sitting on the couch and I think I felt complete and total despair is the only way to say how I felt. And so this nun walked by and she turned and looked at me and said, is there anything I can do for you? And I realized that no one could help me, that just no one could help me. So I said to her, I said, no, thank you. And she left. And so I got up and I went into the chapel and I was just kneeling there. And I have no idea, I doubt seriously I was saying anything. I think I was just looking at the cross above the altar. And then out of the blue, out of the absolute blue, suddenly everything went gold and the crucifix started shimmering and the room was shimmering. And I had this unbelievable experience of God loving me. And I jumped up and ran out and ran to my room And I was standing in my room and I said, I think out loud, I said, I love myself. And the very minute the word myself came out of my mouth, I knew I had been completely transformed. Because up until that point, I would have never said that. I would have said, I love you, because I had no sense of myself. I thought of myself as you. And the minute the word myself came from my mouth, I knew, and I've always known ever since, that I would never, ever cross that line again to being crazy.
So that video usually brings up a good bit of discussion, and there are a number of directions one could go with it. In her work with DBT, she's incorporated spirituality, sometimes in a Buddhist as well as a Catholic sense, to give patients the opportunity to connect with what is transformative for them over time. Hope is another issue, as I mentioned, that spirituality can speak to. Judith Herman, in her book, Trauma and Recovery, talks about how patients who've experienced severe trauma need to rebuild their worldview in order to be able to hope again, into one that's integrated rather than ambivalent and torn by trauma. Meaning and purpose. Patients often present searching for purpose and for meaning in their suffering. And clinicians can often help them look for answers in their worldview. If they have a shared worldview, there's more potential for intervention, but there are also unique risks of crossing boundaries and entering a confusing role by doing so. But a spirituality that's reflective and attuned rather than distracted can open one up to questions of meaning and purpose. And there's a literature, as I mentioned earlier, on mindfulness and mental health as ways for patients to get more in touch with what's really important to them. Spirituality can also foster a morality that is mature or developmentally delayed. Chaplains often talk about seeing patients in the hospital who have a spirituality and a sense of morality that is has not been updated since their Sunday school days and needs to be rethought in light of their adult self. And Robert Cleninger, who is a psychiatrist studying personality development, talks about the role of transcendence in helping patients to become more mature and altruistic as opposed to immature and self-centered over time. And then finally, spirituality has implications for questions of autonomy and authority. Religious and secular individuals often differ the most here. Autonomy is a relative value for those who are loyal to a higher authority. And clinicians' clinical strategies may differ on issues such as assisted suicide, abortion, adolescent sex, or same-sex relationships. But within almost all traditions, it's possible to find places where one is accepted and rather than rejected by the other. This is a depiction of the return of the prodigal son in the Christian tradition. So just to summarize, the role of spirituality in relation to existential concerns and what's now developed into positive psychology. In these existential domains, you see on the left, a helpful spirituality, which is engaged, integrated, reflective, mature, and in which someone can feel loved, can lead to someone being more grounded, hopeful, visionary, feeling virtuous or forgiven, and intimate and secure, which are all helpful things in dealing with physical or mental illness. Here's a case example of a patient of mine, a woman in her 60s who was divorced, survived both early childhood and marital abuse, presented after hospitalizations for being suicidal. She was estranged from her family, disillusioned. She had actually gone to seminary later in her life, and she had a lifelong love of nature, but she felt no longer able to believe in a God who had allowed her to become so damaged. Medication and cognitive behavioral therapy were not so effective, and insight was only somewhat helpful. It seemed as though she benefited more from consistent support and volunteering in a nature museum, but she continued to struggle with whether her troubled life was worth living. So usually I talk with my audience about what might be helpful to a patient like this. It turned out having a dog was a very helpful part of her recovery, but also finding a local church in which she could again experience being loved and renew her relationship to God was actually the most transformative factor in her going on to do well. So I want to talk a little bit about the relationship of faith communities and mental health. Pastors and chaplains counsel individuals with many types of emotional, relational, and addictive problems. They're often the first line for emotional problems in surveys. Faith communities offer meaning, belonging, forgiveness, ways of giving back through shared transformational experiences, service opportunities, programs such as Celebrate Recovery, which in the US is a Christian 12-step program that originated in California. But faith communities can also reinforce mental health stigma and the view that it reflects simply a spiritual weakness in need of more prayer. Here's a brief outline of the spectrum of spiritual involvement that one might have in a patient's spiritual life, again, from the point of view of a psychotherapist, but a physician who has a counseling role could apply this as well. And on the left, you see the spiritually avoidant position, where it's sort of don't ask, don't tell. Someone who's basically competent will do some kind of assessment, listening, as I mentioned earlier, and formulate how their spirituality relates to their illness and recovery. Someone who's spiritually conscious would be recognizing what the patient's needs were and try to refer them to some resources, whether it's to their local parish or whatever spiritual authority they recognize in their life, or a hospital chaplain who might be interdenominational in our setting. Someone who's spiritually sensitive might be interested in going further to help the person integrate their spiritual and their emotional concerns and actually collaborate with a pastoral counselor. And then there are clinicians who are spiritually oriented, who offer things such as spiritual direction, pastoral counseling, and healing prayer. I would say that's unusual in our context, unless someone is formally trained in both spiritual and mental health disciplines. But at McLean Hospital, which is one of the Harvard hospitals near me, David Rosmarin, who's a Jewish psychologist, has published about his use of spiritually integrated cognitive behavioral therapy in patients who are admitted for a partial hospital program, in which they talk about the relevance of spirituality to their psychiatric symptoms, the integration of spiritual beliefs into their cognitive restructuring, and the use of spiritual exercises in behavioral activation and self-care. When they surveyed the 45 patients that they studied, over 90% found the group helpful and respectful. And the tangible integration and forum for discussion were the most helpful aspects. Some would have preferred a more explicitly religious focus, which wasn't possible in that secular setting. And then there's a group of centers now on the West Coast of the US and now in the Midwest that fosters Muslim integrated treatment. The Khalil centers are typically staffed by mental health professionals who are practicing Muslims and able to talk with patients about the relationship of their faith, what it teaches to their mental health struggles. I'll say a little bit about the ethical and clinical challenges that present when one approaches this interface between especially mental health and spirituality. There's obviously the potential for undue influence by confusing one's spiritual and psychological role, trying to become a spiritual authority for a patient rather than a clinician. And the American Psychiatric Association has a resource document that addresses that. The questions of boundaries regarding informed consent, self-disclosure, dual relationships have been addressed also in the literature. The question of promoting faith for its health benefits and whether that sort of distorts its essence has been addressed by a number of authors as well. You don't want to recommend someone marry just because it's better for their health in a statistical sense, and you wouldn't want to recommend faith just because it might be better for the person's health either. Competence, whether spiritual care is beyond the clinician's expertise, is a question that's been raised by Dr. Sloan at Columbia. And then the question again of transference and countertransference, how we consciously or unconsciously respond to patients with different or the same religious orientations to us, are things that we need to keep track of when we're trying to do this kind of work. Some of the principles that are relevant here are that self-disclosure should generally be kept to a minimum in psychotherapy, but is appropriate at some times, like about one's qualifications. And it can infrequently have an important therapeutic impact. These situations need to be thought through, and it must be clear that they serve the patient and not the therapist. This is a guard against proselytization in the clinical context. Dual relationships can cause boundary confusion with someone as part of the same congregation, for example. Whether a boundary crossing is harmful, a boundary violation, depends on careful attention to the clinical context. Guttal and Gabbard have written very well about this. And then transparency and informed consent, why one is or is not dealing with a patient's spiritual concerns, can clarify and help to maintain boundaries. There are a number of resources, especially in the psychiatric realm, for more information on these issues. There's an American Psychiatric Association caucus on spirituality, religion, and psychiatry, which I've been a part of. Division 36 of the American Psychological Association has an extensive bibliography, published books, and a journal. The Royal College in the UK has an interest group that's very active. We've mentioned before the APA Mental Health and Faith Community Partnership, which has a nice guideline for clergy and faith communities dealing with mental illness issues. That's available free and online. And the WPA section on religion, spirituality, and psychiatry has sponsored several global conferences on mental health and religion. There's also a spiritual competency in mental health course that's available online that was developed a couple of years ago. So I'd like to conclude by just quoting William James, who's one of our American heroes, whose book, the varieties of religious experience is still a classic. He said, religion is a man's total reaction upon life. I think today he might have said spirituality. And then he also said, my thinking is first and last and always for the sake of my doing. He had a pragmatic orientation to this area. There are a lot of directions that obviously one could go in thinking about religion, spirituality, and medicine. But I think it's helpful to think about what's the practical outcome that we're looking for. How does this serve the patient? How does this serve their getting better? Thank you very much for your attention.
Thank you so much, Dr. Peteet, for this wonderful presentation and the many questions that you raised to us. And let me ask you a question that it's also my question. In Europe, we have a solid wall still between science, medicine, and religion. How easy is it to break down this wall in order to respond to our patient needs you just presented? What are the practical steps? How did you overcome this problem the last 20 years?
Well, that's a great question. I'm not sure that we've overcome it. I think that some of the scientific research on health outcomes of patients, for example, with serious illness, that Dr. Balboni will be able to talk about, has been very helpful in getting attention to the practical relevance of this area. The fact that patients say that they want more help with their spiritual life, the fact that their quality of life is better, that they have less aggressive care at the end of life when they have spiritual care from the team, and that maybe they're, as a result, the costs of care are less even, I think are all helpful. And again, palliative care has really grown in the States to the point where it's much more easy to talk now about spirituality in the clinical context.
Thank you very much. Another question, very, very specific, is have you studied potential differences to your approaches between the different religions and or dogmas? And the specific question is between the Eastern Christianity, the Orthodox theological approach, and the Catholic or the other Christian dogma churches. Have you studied and found any differences, whether it helps you or not? You did mention about the Muslim integrated, but between the different Christian churches and dogmas, have you found any?
No, I wish I were more knowledgeable about that question. I've certainly seen patients who come from different traditions finding different things helpful. But I've not seen that really studied.
Well, Greece is a small country. Russia is larger, but there are large Eastern Christian populations that might be of help to your new projects as a comparison groups.
Thank you, yes.
Yeah. We are indeed very grateful to what you have done all these years. And really, we feel like you are the mentor of what others in the world are trying to do, following your steps. We thank you very much for your time. I know it's very early in Boston, and you had to devote a special time from your busy time for us, and we want to thank you again and look forward perhaps for another meeting with you in the future. Thank you so much.
Thank you so much.
Thank you. Bye-bye.
Bye-bye.